It's not just about menopausal patients, right? The sexual health concerns span the full life continuum. There's a slight peak at the perimenopausal, menopausal years, but it's actually a slight peak. The issues are broad throughout the reproductive and post-reproductive years. So I think the biggest takeaway is just to ask about it. And I know we are all so busy in clinic. People are trying to get through so much in 15 minutes. But if you just ask about it without the promise of addressing it then, and just keep basically establishing a safe space for them to bring it up. Because we know about half of our patients are unsatisfied with their sexual health in some capacity. So you're going to get a lot of, yes, I'd like to talk about it responses. So it's really interesting. There was a study that was done that looked at what are the barriers, what are the patients concerned about in talking about sexuality with their physician or their clinician. And it wasn't just that there wouldn't be a cure or an answer for their concern. It wasn't that they would just be embarrassed about it. An equal number of people were concerned that the doctor or the clinician would be concerned and embarrassed and get red in the face, et cetera. So I think just making a comfortable space to address it is just really key. And I would just start with an open-ended question saying, do you have any concerns about sexual function? And if you get the sense that the patient's really shy, you can normalize it first and you could say, many patients have concerns about their sexual functioning. How about you? And if they say, well, yeah, you could just leave it open-ended and say, tell me about it. What really differentiates the diagnosis HSDD, hypoactive sexual desire disorder, from just low libido in general is that it's without an obvious cause. So if there's pain, if there's relationship discord, if somebody has a lot of stress going on, that everybody's libido can be impacted in those situations. But for it to be truly considered a disorder, it has to be a persistent problem lasting at least 6 months without any other obvious triggers, and most importantly, it has to be distressing to the patient. So a concern about sexuality and libido that's distressing to the partner, but not to the patient, although it's important to discuss and sort it out, that's not a disorder. Yeah, this is a great question. I mean, there are very, very few scenarios. I can not think of many scenarios where a vaginal hormone to treat GSM may not be appropriate. So in fact, the American College of Cardiology has a great statement saying, regardless of whether they've had a blood clot, stroke, those kind of traditional reasons we may withhold postmenopausal, systemic hormone therapy is not a reason to withhold treatment for GSM. When it comes to individuals who have a history of a hormonally driven cancer, such as uterine cancer or breast cancer, all guideline societies agree. You could try non-hormonal treatments first because a lot of times it can be effective. Moisturizers, lubricants, etc. But if they're not effective, then offering low-dose vaginal hormones is completely appropriate with shared decision making. And the key is on the low dose. So you just have to be careful about what you're using. There's a FDA-approved DHEA formulation that stays under the radar in terms of systemic absorption. There's also multiple vaginal estrogen formulations, and the key is 10 micrograms or less minimizes absorption into the system. So if you're using a cream to minimize absorption, you stick to about 0.5 gram or less near the vaginal opening introitus, the outer third of the vagina, and that will minimize absorption if you're concerned. It's interesting, we do have some great FDA-approved products that are completely underutilized, and it actually frustrates me a little bit that people will make fun and say, oh, it makes you tired and nauseated, haha, why would you use it? So just to talk about them, the two main non-hormone treatment options, there's a daily medicine called flibanserin, and people joke about these side effects, but the reality is many people have trouble with sleep. So a little bit of a sedating property is a great solution if you're having trouble sleep. It has appetite suppressing effect. There can be some weight loss. That's where the nausea comes in. So those are not necessarily negatives for some patients, right? So it's all in how we talk to our patients. So the flibanserin is a nightly medicine that's used. It can be used by premenopausal or postmenopausal women. And there is a bremelanotide, which is an injection. That way, if somebody doesn't want to be on a medicine on a regular basis and they just wants to use something a few times a month, that they can do that, and it lasts in the system for about 24 hours. The bremelanotide, though, has only been studied in premenopausal women, so that's where it's FDA approved.